Burns. Symptoms. Pain is the primary symptom of burn injury. Signs. First-degree burns, present with redness, mild tenderness, and, occasionally, slight swelling of the involved skin. Superficial second-degree, partial thickness, burns, may have intact, thin-roofed, bully, red, moist, denuded areas that are tender, or both. Deep partial thickness burns appear paler, drier, and more mottled than superficial second-degree burns. They are not always tender and may be difficult to distinguish from third-degree burns. Third-degree burns usually appear white or charred, dry or leathery, and are anesthetic. Surrounding areas of second-degree burn may be tender. Percentage of total body surface area, BSA, of burns, second and third degree only, are estimated using a chart. Proportions change with age, with younger children having a relatively larger head with smaller torso and legs. 1. The area of the palm, without digits, is approximately 1% BSA. Electrical burns may appear as small areas of first or second-degree burn or, in severe injuries, a deep, depressed entry wound and blown-out exit wound. Investigations. Minor burns. Minor burns require no laboratory studies. Larger and major burns. Complete blood count with differential, to ensure that over time oxygen carrying capacity is maintained and infections are identified early. Blood urea nitrogen and serum creatinine measurements can be helpful in fluid management and to identify renal impairment. Type and hold for possible blood transfusion. Urinalysis, for myoglobinuria in third degree and electrical burns. Arterial blood gases, to monitor pulmonary function and acid-base status. Co-oximetry, to identify and quantitate carbon monoxide poisoning. Chest radiograph, if inhalation injury is suspected. Measurement of central venous pressure, can guide fluid management. In major burns. Bladder catheterization with measurement of urine output, for fluid management. Culture of burn, to identify potential pathogens and guide antimicrobial treatment should an infection develop. Electrocardiogram, for serious electrical burns. Complications. Burn shock. Inhalation injury, airway burn/obstruction, pulmonary injury. Carbon monoxide poisoning, cyanide poisoning, or both. Infection. Scarring/contractures. Thermal, electrical, or chemical energy. Damages the skin and underlying tissues. Temperature, duration of exposure, and thickness of skin determine the depth of a thermal injury. Large surface area burns result in failure of the skin to preserve fluid, regulate temperature, and provide a barrier to infection. Mediators released from large burns cause systemic effects, including diffuse capillary leak, myocardial depression, and hypotension. Hair follicles and sweat glands in the deep dermis provide cells for reepithelialization and healing of burn wounds. Full thickness and some deep partial thickness. Burns require grafting treatment. Diet and lifestyle. Not applicable. Pharmacologic treatment. Major burns. Estimated total fluid for first 24 hours 4 ml/kg/% BSA, add. Maintenance of 5 years and 5,000 ml/m2/% BSA, add 2,000 milliliters per square meter per day. Maintenance. Give half of fluid in first 8 hours, half in next 16 hours in addition to constant maintenance rate. Use crystalloid, Ringer's lactate, in first 24 hours. Do not add potassium, because potassium may be released from damaged tissues, and renal failure may develop. Follow urine output and peripheral perfusion. Revise fluid rate as needed. Administer analgesia. Standard dosage morphine sulfate 0.1 to 0.2 mg/kg intravenously as needed for pain. Cardiovascular status should be stable before administering Nothing by mouth at 15% BSA because ileus is common. Consider NG tube. For larger burns. Non-pharmacologic treatment. Major burns. Stop burning by removing burned clothing and irrigating caustic exposures. Cover burns with clean or sterile sheet. Intubate early for stridor, signs of inhalation injury, or burn shock. Administer 100% oxygen if burned in a house fire or closed space, or if the child is in shock. Gain vascular access. For burns greater than 10% BSA, use peripheral intravenous catheter, central venous catheter, greater than 65%, 2 central venous catheters. If possible, place catheters through intact skin. Minor burns. Wash with soap and water. Debride broken bully by wiping with gauze. Intact bully should be left. Unless they are in areas that will rapidly rupture, hands, flexion creases. Dress minor partial thickness burns with antibiotic cream/ointment, silver, sulfadiazine, bacitracin, and dress with layer of absorbent gauze. Minor burns. Analgesia. Tetanus prophylaxis. Treatment aims: to keep child warm, to maintain intravascular volume, to minimize risk of infection, to keep child as comfortable as possible. Prognosis. Burns of greater than 30% BSA are life-threatening. Greater than 50% are frequently fatal. Superficial second-degree burns heal with minimal scarring. Deep second-degree and third-degree burns usually result in scarring. Skin grafting usually improves the cosmetic result. Follow-up. Minor second-degree burns require once or twice daily dressing changes. Larger burns should be assessed for proper healing by a physician during the first week after injury.